scheduled, of course, the last webinar following the technical glitches that we were experiencing. And yeah, we learned there's just so many things that could have possibly happened. International Google timing out, or somebody might, maybe a speaker hit the wrong button and then it ended the session. But whatever the case might be, we are here now, and we really appreciate your understanding and your coming back to us. We were hoping that we would have Jamel as taking the first lead, but without him, I don't know what's happening. He hasn't communicated from his end. I'm trying to call him. We will then have to work with the speakers that are here. Tabisa, are you in?
Yes, Dr. Munya, I'm in. Good afternoon, everyone.
You. So with the colleagues we had, we brought 3 speakers. Tabisa is coming from the policy side of things. She's working with the national department, the provincial department of health and well-being in the Western Cape, where they are doing some work there regarding African indigenous health practitioners, and also bringing them into the conventional biomedical care system. And then we have here Sister Priscilla. She's a professional nurse in the Free State Department, and that is also largely from a practice. So we have Sister Priscilla giving us a practitioner perspective, and then we have Tabisa giving us a policy practice perspective, and then Jamel was going to give us a philosophical, and philosophical take, much as he himself is also an African indigenous healer practitioner. And so the 3 perspectives are now going to help us to enrich the conversation. And then thereafter, we will get into a question and answer session as well as discussion, and then we'll take it from there. So let us start with Tabisa, if that is fine with you. And then we'll have Priscilla. We'll find out whilst this is going on, what could have happened to Jamel. He's out in Jacobsdale, near Kimberley there, so we don't know what could have happened. We will continue to explore and find out what is going on his side while we hear the 2 speakers this afternoon. So thank you very much, colleagues. And so over to you, Tabisa. I think the idea is just to give us a good 15 minutes of your highlight thinking in terms of who you are, what you are doing, and what it is aimed to do, and what are some of the issues from a policy and practice perspective from your side that could enrich the debate. The idea is not to say everything or to say all, but I think just to steer the conversation for the benefit of the audience that is in the room, and we take it from there. So thank you very much. Over to you, Sister Tabisa.
Good afternoon, colleagues, and thank you, Dr. Munya, for inviting me into this conversation. My name is Tabisa Mpazwa. I'm at the Department of Health and Wellness in the Western Cape, specifically at Khayelitsha Eastern Substructure. Our engagement within the space of indigenous healing or traditional health practitioners is a relationship basically that started during COVID time. As you will know, we were challenged with having to engage different stakeholders within our spaces and those who are practicing all kinds of practices. So we then engage intensively with traditional healthcare practitioners at the time, because if you remember, our system, as far as the healthcare system is concerned, was in a crisis mode, where we needed to have a relationship or coexistence, which we have been talking about in paper. Because this relationship, to be honest with you, Dr. Munya and everyone, is a relationship that is within policies. And it's a relationship that we know we should be engaging in. And it's also a relationship that should be coexisting. However, it's a relationship which we have found to be quite challenging to put in practice. There are different reasons that perpetuate that narrative, that we have not done anything as far as this relationship is concerned. One of the reasons is the belief of some people of the practice, because unfortunately, the Western way of doing things, something was proven in a lab in order for it to exist. And then it questions the existence of traditional healing within our spaces where we are governed by Western thinking. However, during the time of COVID, we had to evaluate these beliefs and we had to look inside and say, this is what the policy says. Are we practicing what the policy is saying? And also it amplified the voices of African people of saying, Western medicine is not the only medicine. And as you will also know, or everyone will know, 70% of South Africans are using traditional care. And with that then in mind, I'm one person, as you know, Dr. Munyo, who openly say, I practice and I believe in traditional medicine as myself, as Tabisa. So if you are looking at me holistically, you cannot then think that Tabisa is Tabisa, yes, understand Western medicine, but Tabisa is an African woman who believes in African ways, who believe in African medicine, and who also consults African religion. You know, I do that openly and I don't shy away from that. And if you then look at the system, the Western system, as far as our hospitals and clinics are concerned, we are not embracing that. It is easy for our Western systems or hospitals and clinics to welcome someone who says, I'm taking Chinese medicine. It is fine for us to welcome someone who says, I'm a Hindu and I want someone from my culture to come and have a ritual or have something with me while I am in hospital. We are fine with that. However, we are finding it very difficult. We know that as far as the system is concerned, we are not welcoming traditional healthcare practitioners to come into hospitals. And then it then question our existence that even within Africans, we tend to look down on this. So that's why then we then were very intentional in saying, what do we want to achieve and who are we? And how do we bridge the two? And how do we then, beside now taking it out of policy and say we are actually opening these doors and we're actually being intentional in having these conversations then with traditional healthcare practitioners? And how do we upskill those who are within the African tradition to the context of what today's challenges are? And one of the things that even the traditional health practitioners have spoken out to is to say some of the things that our ancestors used to deal with are not what we are dealing with currently. So we do have an open mind of saying, what do we need to learn as far as the Western medicine is concerned? What do I, as a traditional healthcare practitioner, need to understand about high blood pressure, about diabetic, about cancer, in order for me, when I do make something for a person, to be mindful that this person is taking other medication? And then that have also built into the relationship that we have with African Center of saying, how can we then sit down and create modules or studies and say what can we do in order, one doesn't have to be a medical doctor, but how do we bridge the two? How do we bridge just the common knowledge of when you are consulting someone whom you need to assist? Be mindful that there are other conditions that the person have, and how do you then mix for the person in order for whatever they are taking, it doesn't compromise the medication that the person might be taking, even though the person might want to do dual. As you said in our last engagement, when we started this conversation of saying, I'm coming to a hospital, do I have a choice of saying, do I want to be seen by a medical doctor? Do I want to be seen by a traditional healer? And we are far, very far from that in South Africa. But how do we still, knowing very well that we are far, coexist and making sure at least we meet each other somewhere, which then means both sides need to sit down and both sides need to understand that we need to coexist, and we then need to stop undermining the other one and thinking that the other one might be better, because in our African context, none is better. I coexist in both of them, and I'm comfortable in coexisting in both of them, and I get different things from both of them, Because if you're looking for me, for instance, on an emotional and spiritual as a being, I don't get that within the Western medicine, but I get that within my traditions and my ancestors and everything, which makes me whole. And whatever I believe in will help me. It will help me, because so I need to be then looked into as a holistic person. So I think that is where we started our conversation, and that is where we are landing in the space of saying, how do we make sure that we open our doors for traditional health practitioners to exist in our health system? And what does the policy say? And do the policies also talk to African traditional medicine? We understand, because sometimes when we're talking about writing a policy, even that is a Western way of doing things. And the question becomes, were they included in the policy? Do the policy talks their language? And if then that is not the case, how do we start those conversations and making sure that we are real in the conversations that we're having? It's not us again writing policies because we think we know better. It is actually coexisting and writing these policies with African traditional healers, and that will then be taken forward. Thank you.
All right.
Hi.
No, thank you so much. Jamel, I think is still not in the Anya, do you see Jamel on the room yet?
No, Munya, I don't see
Asking
him.
this
No.
question just so that I take advantage, and then this becomes an all females speaker panel, except for me, who is bringing the patriarchal element. But otherwise, whatever been in that regard. No, thank you very much for that, Sister Bisa. Really appreciating your inputs there. Colleagues, I think we've heard it all. Sister Bisa saying there is no better than the other. Why don't we coexist? And in fact, in the typical Ubuntu fashion, I am because you are. And these systems somewhat talk to each other, and they all come from very different contexts and use different rationale or cosmologies. And so how then do we bring them into the space so that people then enjoy the full democracy of having to choose how they want to be attended to, in terms of their health. So yeah, as we continue to explore these practical realities, opportunities, and challenging of integrating these indigenous health system practices into the South African health governance, it's a number of issues for me. I think that then come into context here. This is about equity. This is about ethics. It's about inclusion. It's about restoration. It's about integration, and it's about epistemic justice and full choice to the consumer or to the client, as they say. I don't like the concept of client, but I find health facilities tend to use that concept of clients. So if you are indeed the client who is buying a service, imagine how much of, imagine a situation where you'll have to choose whether you are buying from ShopRite, you are buying from Pick and Pay, you are buying from Checkers, you are buying from Woolworths, or whatever the context in your own context, the various, service providers that then one finds, and then you choose where you want to go out of your democratic right and choice, respect of your choice, and also even out of your own pocket and affordability in terms of what sits well and right with you. So, Sister Bisha, thank you very much for opening that up. We shall want to hear. I have a lot of questions in terms of how this is happening, and particularly in the Western Cape, given the way some of us tend to perceive the Western Cape in terms of, the national dynamics and politics of this country. It's very interesting for me and illustrative that this is happening in the Western Cape, and it'll be interesting to find out how the other provinces and even in other countries, particularly of the speakers in the room, are taking and experiencing this. Sis Priscilla, over to you after that hard act by Sis Tabisa. Over to you, Sis Priscilla.
Good afternoon, and thank you so much once again for the invitation. As introduced, I'm Priscilla Munyobo. I'm a forensic nurse. I've been practicing forensic nurse for the past 15 years, if not longer. For those of you who might not know what forensic nursing is an intersection of the legal framework or the medical framework, where we're focusing on managing victims of gender-based violence, or survivors, as most of them would prefer to be called, or victims or survivors rather of sexual violence. Now, I came across the speciality way back in the Northern Cape. I'm originally from the Northern Cape, working in a medical ward, seeing this young patient coming for the third time in 1 month with attempted suicide. She wanted to take her own life. So as we all know, healthcare provision, like Thabisa indicated, we mainly just focus on the medical aspect. So I had a conversation with her, just trying to get to the reasons why she's attempting to take her own life. And she shared that, apologies, she shared that she was being sexually abused at home. And and it's then that I realized that because this service was mainly medical officer centric, it was mainly a service that was being rendered by medical officers, what you call your doctors, mainly at your GPs, where most of the time survivors would report after hours, and then they'll be seen at the GPs after hours. And the conditions were also not very conducive. They were also not meant really for survivor centered, as and when we progressed in managing victims of survivors of sexual violence, the compassion and the different aspect of care came in. And it still continued to be mainly focusing on the biomedical side. And as most of you would be aware, when you're a victim or survivor of sexual violence or gender-based violence, your body, we call it the crime scene, where we will then undergo taking forensic evidence from your body. So I discovered the gap in terms of the spiritual aspect, the deep psychosocial care, the lack or gap in terms of cleansing, because most of them felt they didn't feel dirty on the outside. They felt violated deep within their own being. So I discovered that there's this huge gap. So after then undergoing training in forensic nursing, I then transferred to the Free State province. And in 2015, that's where I met Jay. We trained medical officers, because most of them, in as much as they go through their medical training, there's no training on sexual violence. There's no training on gender-based violence. So we had an integrated training where the doctors, the nurses, the justice system, just to raise and sensitize them in terms of managing the survivors holistically. But I then still realize that there's this gap still when it comes to the indigenous medical care for survivors of gender-based violence or sexual violence even. So in 2015, as a Free State, we piloted. We had training in all 5 districts in the province, where we invited our traditional health healers and practitioners to train them, mainly just to raise awareness, because at times the statistics that we see, the crime statistics, particularly your gender-based violence, your sexual-based violence statistics that get reported, in as much as Thabisa indicated that some of our communities would prefer presenting themselves at the traditional health practitioners, this data is missing in your crime statistics that normally get shared with the public by the Ministry of Police. So we also realized that there's this other gap, which resulted in massive underreporting. Generally, sexual violence and gender-based violence is generally underreported, worse for those that would prefer to seek help and assistance because they feel dirty, they feel that their being has been grossly violated. Hence, then the intervention, the pilot that we had back in 2015 with then the traditional health practitioners in the province, where we trained them, we raised awareness, because as I indicated, the body of someone that has been sexually violated is a crime scene. So them going straight to a traditional health practitioner, then there's contamination, because they'll be cleansed. there'll be rituals, and then there's this risk then of contaminating or even cleaning this very critical forensic evidence that we'll need to assist them in their journey in the justice system. So there's that gap that we picked up and we trained. Unfortunately, as I indicated, it was a pilot back in 2015, and I moved out of the program. We haven't sustained that, and hence us then collaborating with Africa Center just to see how then to expand and expand this to other interested practitioners who might be interested in really knowing about the healthcare side of sexual violence and the interlink with indigenous health knowledge. And Thabisa, you might also be aware that there's been progress made. We have Traditional Health Practitioners Act in the country of 2007 that is currently being reviewed, and I think Jay is also in the forefront of reviewing that act. We have the WHO Traditional Medicine Strategy, also realizing and recognizing the importance of indigenous health systems and healthcare. Hence, then the importance then of expanding and including all the important stakeholders to so that we journey together to ensure that there's integration for people-centered care. That's strategy 3 of the WHO Traditional Medicine Strategy, objective 3, just looking at the people-centered and integration. That already a platform in terms of guidelines and tools from WHO has been set. I believe that also requires some review because it was 2022 rather up to 2023. So we also probably need then to look into reviewing and ensuring that we're not only talking let's collaborate, we're intentional about taking our indigenous health systems along the particularly on sexual violence and gender-based violence, because it's becoming actually a pandemic in the country. We know the pressures of the high numbers of sexual violence and gender-based violence in this country. So the importance then of us collaborating intentionally and ensuring that from us engaging then to ensuring that we have programs that will then ensure that we all come along on this journey to ensure that we integrate in a true sense, not only us talking amongst ourselves, but bringing along the powers that be, the policymakers, to ensure that we really integrate this very important service to ensure that there's pluralism in managing survivors of gender-based violence. Thank you, Dr. Munya.
No, thank you so much there, Sister Priscilla. Yeah, I've read about forensic nursing. I'm very far from it. I've never spent a day or even hours in the training in the space, but just from my own reading of it and dealing with a lot of this, I've heard quite a bit of forensic nursing. But you've given it a particular perspective for me that just really lands, and in as far as I'm concerned, in terms of the gap that has been found in the people-centered healthcare. And then, I think if we're talking people-centered without understanding a people's culture, beliefs, and cosmologies, how then do we bring a health system that is centered according to those, to the people that are concerned? And in this particular context, if we look at our own context in the context of Africa, when one applies the concept of indigeneity at a continental level, how people-centered is our healthcare system that we are working with? What are some of the gaps and some of the shortcomings that it has? And particularly, I think when it brings in the spiritual dimension and element, that is very absent in the in your Western-centric medical health system, as it were. Particularly given the importance of spirituality, that we see many times. In the global south generally, where people talk of cleansing, there's cleansing that must happen when there's been death. There are rituals that are associated with that. There is cleansing when people have been violated, in the context of violence that comes through issues of sexual and gender-based violence and issues of even femicide, as we know. Then how then do we integrate this kind of training, and particularly even the servicing of that? Interesting for me, I think you are raising the issues of the body as a crime scene, the contamination of the body. Once a body has been violated, particularly of the minor children that may not even understand or know, and not even it's not even any better for the adult person. But if an adult person can at least make sense and be able to relate, imagine, I think, the stories that we've often had of children being, raped, babies at it were not even just children, or elderly people, who get abused in the process. Then how does the medical system that we work in today, the Western-centric one, how does it help people to cleanse, if anything? Things that then happen inside the inner person, in the body, in the deep, core or spirituality of the person that might have been violated. So yes, I think clearly you're demonstrating there and highlighting. And I like also, I think, the concept that of intentionality, Sis Priscilla, that you are raising, to say, look, let us not just talk about these things, but let's be very intentional to bring about policy, to change policy. And I've always seen policy as it may be what that is, which is written down and prescribed, but policy may also even end up being what we are doing, the practice that we actually do, if it is not prescribed in our legislations and policy frameworks, as it were. But then the idea is for us to bring about the awareness, the discussion, the solidarity that is needed for us to raise and to bring about the awareness, amongst ourselves. Personally, I think I've always struggled with the concept of traditional health or traditional medicine. I might have mentioned this in our first webinar on Wednesday, when before we had the technical glitches, that I really believe, I think, in the language and concepts of indigenous health or indigenous medicine, as it were. Because the moment you talk traditional, immediately you are talking about modern. And the moment things are talked about traditional and modern, the bias tends to be for, it tends to be that which is modern is better than traditional. In the same way, we talk about rurality and urbanism in terms of when people say you're from a rural area, then it suggests that, you are not glued up. We are not as sharp, as intelligent compared to the one that is coming from an urban context. So anyway, that is really the reason and concept from my side, I think, in terms of preferring indigenous, health, indigenous medicine vis-a-vis traditional. That said, colleagues, I then would like to open up, the conversation with those two speakers. We have no idea what has happened to Jamel, but we want to believe and think that he is okay and well wherever he is. We will be updating, as and when we get any updates from his side. But that is as it may. I think it was just meant to be. It was meant to be two ladies who are supposed to be speaking to us, and there it is. You have heard it. A practitioner side, and then a policy side. The policy that is a policy side that is being informed by practice. So, colleagues, if there are any questions or comments, appreciation, the floor is open. Please join us and then share your thoughts and your views, and then we just take it from there. Thank you very much. Over to you. Yes, Sister Tifa Stanley, I see your hand is up. You can take the floor. Please share your question.
Thank you very much, Munya. It's Tafatwa here. And thank you to the first presenters. That was very empowering. But mine is a question on the first speaker spoke about coexistence, and coexisting between Western health and traditional cannot coexist without religious as well. How do we break the barrier of taboos that traditional or indigenous medicine is associated to witchcraft and the like? How do we, decolonize the mindset of the conflict between religious and traditional? Thank you.
Thanks, Tafide. Sorry, I was attending to a call that came through. I thought it was Jamel, but I think from the bit that I had, I don't want to think that you are here by mistake, Tafazo. I think already these conversations, as we have them, it is part and parcel of a deliberate conscientization, a part and parcel of building a movement that understands that is to have a critical take on most of these issues in terms of when what I've learned is that when people do not understand a thing, the best way is to bastardize it. Have you ever realized it growing up that you'll find people that would say, if I want something and I cannot get it, then I start telling that it is cheap, or it is not so great after all, because either I've been rejected, or I've not been able to afford it, or I do not understand it. And then instead of joining, then the issue is to bastardize it. And I think we all see it, particularly even in the spiritual realm and religion. We all know how colonialism has worked adversely in our context, where you get told, oh, you're Tafazwa. Tafazwa is not your proper name. What is your proper English and your proper Christian name? So you are talking to one person that must have two identities. One is proper and Christian, and then the other one means it's pagan because it's not Christian. So if you are not Tafazwa, as your name, as suppose that is Shona for Tafazwa, that we are pleased or something like that, from my understanding of that what that name might mean. So then people would say, no, look, Tafazwa is the pagan name. It's not a proper name. We want to Christianize, to Christian you, and then we call you Matthew or James or any of the names you find in the Bible. Then that way, only that way, we begin to observe, we begin to recognize you as a real person with a proper name. And because we do not understand these aspects, particularly the African cosmologies that come with the very deep spiritual aspects, that when, Western science does not understand that, and it cannot laboratize that. And as a result, you get people having to say that. But anyway, it's not for me to really answer, but that's just a thought I have. Professor Duku, I saw you had your hand up. You wanted to respond, or was that an additional or separate question?
Good afternoon, colleagues. I did not want to respond, but I think, colleagues, this is the space aims to challenge what we thought we were yesterday, right? I attended, was it yesterday or day before yesterday, when I think Dr. J and the other colleague were talking about the plurality of the health systems, right? And I'm knowing that the plurality moves more towards the Western, the biomedical side than the traditional. So it's like today, as I'm listening to my colleagues, just like you, I'm thinking we are missing Dr. J. Dr. J, who was going to talk about the epistemology and the ontology, of the indigenous knowledge systems, because by the way, I am a teacher trainer, right, from the University of Forte. And when we're talking about issues of inclusive education, because from that day when we met for the first time, we were talking about inclusivity, and in my classrooms, in my lecture halls, I talk about inclusive education. But then when we talk about inclusive education, and you look at the tools, that the Department of Education is using in responding to issues of inclusivity, we use mostly the biomedical tools. For instance, if we talk about the Sears model, but I think for me, Priscilla, you challenged me when you talked about the body being a crime scene, and I'm like thinking about myself as a crime scene, because if as a traditional healer, somebody who is still in the process, when I have to go and respond issues of African traditional healing, I have to go to a medical doctor to get a medical certificate, because as you were talking about, how do we you know, how do our policies respond to what we are as Africans? You know, challenged about that because I have to go to a medical practitioner and get a medical, certificate, because where I am, they do not understand that as igqirha, I have to go and pay emlanjeni for a particular, time for my own healing. So colleagues, I'm thinking that, as I think it was you, uh, Buti, who said maybe we are into a movement. I'm very I'm very emotional. I am very excited, about us, talking about us, where we are and where we want to be. Thank you very much, colleagues.
Thank you very much, there, Sisi and Tombozuko. I think you should have introduced yourself, actually, and if you don't mind, show your face. This becomes part and parcel of the movement building so that we know each other spiritually, facially, by voice, and other things. And of course, I know that at the University of Fort Hare, despite the challenges that you have had with the student protests, you had an indigenous knowledge systems, IKS, your annual conference postponed
Yes.
from October to the 1st and 3rd of
Yes.
December. And this is one of the ways I think that we have to be building this movement by getting to know each other, by getting to collaborate and work with each other, by building the message and passing it on. We are poorer for lacking some of these things in
Yes.
understanding, but our children cannot be any poorer than we are because we are the poorest of the poor in that sense, at that level. So maybe over to you. You may want to introduce yourself, Professor Duku, that people see and know, and then, of course, talk about your event. That is the continuation of the conversation. It doesn't end here in this webinar.
Thank you.
Over to you, Sisi.
Yes, thank you very much. Kamakwindi, Thokozani, Dawe. Good afternoon, colleagues. I am Langa Duku. I work for the University of Fort Hare in the Faculty of Education. And one of my, because we usually say we have multiple identities. Ndingumamtshawe, ndiligqirha. And I think what I love about our identities is that, contrary to what we have believed, that you cannot be learned and also, identify with who you are, as an African. For me, I think they are moving together very nicely. Um, the academic from the Faculty of Education, University of Fort Hare, um, we are organizing a conference on indigenous from the 1st of December to the 3rd of December. Actually, it was supposed to have taken place in October, but because of whatever that happened at Fort Hare, everybody knows that the University of Fort Hare was in flames. We had to move it to December. So we are hoping that these engagements, as well as the engagement of the 1st to the 3rd of December, we can begin to have a movement that begins to proclaim who we are, not somebody else telling the others as to who we are, because in most cases somebody else tells me as to who I am. So colleagues, yeah, thank you very much.
Thank you so much there, Professor Duku. We really appreciate it. I'm feeling very emotional, and I connect deeply with what you said. And I think Tafadzwa was saying it earlier on, that we have been brainwashed into looking at issues of indigenous systems and indigenous health in particular, associating it with witchcraft. And at the same time, the indigenous health practitioners are then associated with people who are dirty poor, uneducated, and so many other things. And then when we see scholars who are also indigenous health practitioners, professors, and so forth, that must challenge us in terms of our own world viewpoints around the identity and the dignity and persona of an indigenous health practitioner in our context. Yes, then Baneka Zimpumlwana, you had your hand first, then followed by Shelley Abrahams. Please take the floor, introduce yourself so that we get to know each other. This is how we build community. If you are comfortable, show your face so that when I see you next, be it on a flight or somewhere on the bus, I'll be able to say I know you from somewhere, and we continue the conversation. Over to you.
Thank you so much, colleagues. My apologies, I've got a bit of a flu. My name is Banegazi Umlwana. I am the Managing Director at the Indigenous Professions of Southern Africa. This is a very interesting conversation. I'm sorry I missed the first one. I was invited by Dr. Calvert. I am currently championing, as part of the work of our conversation, of our organization, policy positions for the C20 to the G20 around the topic that is being discussed today. Effectively, it is an understanding that equitable health for all really cannot happen without understanding indigenous knowledge systems within their context, within a framework that invests in the legal frameworks of indigenous knowledge itself, so that the languages can be taken care of, and so that children can learn within their worldviews, and so that practice is not assimilated under the disguise of integration. And so we are championing a position that says indigenous knowledge systems are actually fundamental in well-being economies, because the current framework of economy is extractive. It's extractive in thought, it's extractive in spirit, it's extractive in profession. And so we've seen over the years a lot of resistance around practitioners in particular who would want to engage conversations on inclusivity. And that's because the frameworks by nature, are designed away from the worldviews of the practitioners themselves. So I think a starting point in this conversation is very much around appreciating that even in a country like South Africa, indigenous knowledge is very diverse. And what you will learn from a Kamago practitioner in the OR Tambo district, for instance, will slightly be different to a Kamago practitioner in Gqeberha, for instance, even though the framework in itself is more or less the same, but even the environment has influence in terms of how we are seeing practice rolling out. And these are very important and fundamental issues, which I think when we engage issues of policy, we don't get to address, because in the wave of integration, with all the beautiful policies with the WHO and everybody else that come with these amazing pieces of policy, they remain outside of, firstly, they become enabling to extraction, to practitioners, and I'm a practitioner myself. And secondly, they are unable to take into cognizance environment in terms of the ways in which people live. So a very important thing right now, which is on the agenda at C20, is climate change. And there's a lot of conversation around green economies and conversations around blue economies. And often when those conversations are had, there's no practitioner in the room, and yet these are people who are custodians of the different environments where these economies are reliant. And so systemically, we perpetuate a them and us, where there's something more formalized, and for you to be formalized, there's a particular way in which you must, be built and supported. And there's basically no investment into indigenous knowledge systems themselves that is intentional about building a new way and model so that the pluralistic system can really be showcased. So we've listened throughout the consultations, for instance, to practitioners who have voiced issues around feeling like they have to assimilate to what the Department of Health is saying health is. And I think the tension becomes, in indigenous knowledge, we speak of well-being more than we speak about health, because you cannot be healthy if mentally you're not in a conducive environment. And therefore, you will have problems that perpetuate gender-based violence and all kinds of other violences because there's no well-being in the context of the delivery of health, which is much broader. So in the conversation around a community-anchored health response, you cannot think about that simply from a clinical perspective. You've got to be thinking about, how even indigenously, when you greet someone, they will tell you that our river is in the Mbashe River, and our forest is in the whatever the forest that the family is aligned to. So these things become important things, which unfortunately, in the frameworks of health or well-being, broadly speaking, they are nice in policies as ideas, but in the practicalization of it all, even in the models of professionalizing, in infrastructure conversations, it's almost like we are not thinking about really rebuilding a parallel system that will support the well-being of our people. And I think that's the contribution I would like to add to the conversation, to say we have amazing minds right across. But some of the therapies, for instance, when you're speaking about my sister who spoke about forensic nursing, and some of the therapies that are employed when we have to deal with trauma, for instance, those therapies can never be delivered in a clinic setup. They cannot be delivered even in a hospital setting. But the needs of indigenous practitioners to fully enable those therapies are not being met, and they're not being recognized because the environments are not supported in that sense. And I think these are things we need to begin to think about. We also have healers of land, right? Especially in the Kamako system, we have people whose job it is to heal the land. So when you're talking food security, for instance, which is a huge part of the delivery of well-being for practitioners, we are not listening or thinking about the healers of land or the healers of water, for that matter. And all of these are very important conversations to have in the conversation of health delivery. And I think I would gladly support, and I'm very happy for this initiative that is thinking critically about what do we need to do. But I think my challenge would be to expand this conversation around indigenous knowledge system, because even when you talk about innovation mechanisms, even at a country level, it feels as though indigenous knowledge is just a body butter that we are infusing. It's a IKS infused body butter. It's not the actual product in itself. And we need to reform the machinery of innovation so that we really can build a bottom up and understand that you cannot have a continent that has 60 to 70% of its citizens solely reliant on indigenous medicine as a science. And we don't look at that as something that also can enable an economic transformation for jobs. And it is something that really can enable not only the practitioners, but it can empower even the patients of the system. So we've got to be thinking much bigger and begin to challenge each other and support one another, I think, towards really engaging the conversation. Thank you.
Thank you so much, Usisi Banekasi Mpumlwana there. Thank you so much. You have said a number of things, and I think, look, we cannot agree, any less, because there's just so many things, the issues that we are faced with here, the challenges are quite plenty, and I think they are multifaceted with so many different angles that we would need to be able to engage. First and foremost, for us to be able to meet with each other like this, and then how do we network? Tomorrow when we meet in another webinar, it may not be all of us here, but if 2 or 3 or 4 people are able to meet as a result of these webinars, and then they're able to pick up on an idea and run with it. If some of us from here are attending the multidisciplinary annual IKS conference being hosted by the University of Fort Hare, that moved from October to the 1st and 3rd of December in East London this December, and we meet up there and we continue with the conversations. If some of us are doing research, if some of us are pushing towards the development of a training and qualifications framework that identifies and acknowledges the expertise and the knowledge, as well as the practice of indigenous health practitioners, there will be so much more that we can do. But I think, as somebody already indicated in the chat, we would like to pick this matter up and take it further. And I think in 2026, this is one particular thing we want to run with, among others, where we could even bring different national associations from different countries, even your Chinese ones, to bring them together and have conversations. If there are conversations that will enlighten, if there are conversations that will help towards decoloniality and decolonizing some of these things, then I think they're better for all of us. Colleagues, I'll request that you add your names and contact details in the chat so that we invite you to future webinars. Usis Banekazi, I know we are already in contact via LinkedIn. I think what's left is for us to be able to actually meet and get something going. Thank you very much for that. Shelley Abrahams, over to you. Then I will come back to you, Tafazu. And then Alois.
Hi, good afternoon, everyone. I'm Shelley Abrams. So I'm a HEST manager. I'm a nurse by profession, and I have just recently taken up the post as the HEST manager in Klipfontein Mitchells Plain. So that covers the TB, HIV, and STI program. So I was very interested when this notification popped up in my emails, and that's why I joined. I've been listening to everyone. I do agree with the inclusivity that Benekazi spoke about, but I just want to share 2 points from a personal point of view. I will start where I have parents who's both from the Eastern Cape, from Imakloseni, and they very much had a close link with everyone living in that area. My mother's from Katpat, my father's from Aliwal North. But especially from my mum's side of the family, I remember even as a child when we were there, we were at all the ceremonies. When our Makwetas came home, my granny would be part of the cooking and so forth. But so they also brought along the practices of burning the herbs and all that. And I grew up in Cape Town. So in Cape Town, my father was perceived as practicing witchcraft because he also incorporated this traditional healing into how he took care of his family. So, it was a very stressful time. My dad took it a bit further. He went to study and he was a qualified homeopath. And he then practiced traditional medicine that way. But the reason why I'm bringing up the personal part is I think that especially for us who's been classified colored, there's a perception that we don't have no roots, and yet there's a large proportion of us who's from the Eastern Cape, Limpopo, that kind of area, who's had close links with traditional healers and has made use of them. So I think that's probably a neglected part. I'm not sure if someone has looked into that, but it's not just people who are classified Xhosa and Zulu and so forth who practice indigenous medicine. And then from a clinical point of view, I agree that we have to look at trainings because as a nursing student, I wasn't taught about traditional medicine and how I must work together with a traditional practitioner. I only got to understand once I was a clinician that in order for me to make sure that my patient is adherent to medication, that they have the best health outcomes, that I also need to work with them in terms of their spiritual convictions and beliefs and understandings. So I am very grateful to be here on this platform, and I'm hoping that I can join future events as well.
All right, thank you so much
Thank
there,
you.
Sister Shirley. We will then look forward to not just talking, you are not very far if you're in Cape Town. We would love to be able to see how we can take these conversations beyond, and particularly those of us who are in practice, who are in systems where people, where we interact and engage with people, where we influence people that look up to us, where we are in systems that need to change and to accommodate some of these things, and it can change from inside as well as from outside. The perception, like I said, I don't know if you joined the webinar, Shirley. I was saying to Tafadzwa earlier on that most people, when we cannot beat the system, or when we cannot afford, or when we have been rejected by people or other things, we then tend to demonize. We then tend to give it so many different things, especially if we don't understand the complexities that come with African cosmology or cosmovision of health, which is a very, very complex spiritual aspect and dimension that science as we know it today cannot unpack and cannot speak to. So it's one of those things. And then why don't we go, and particularly when we begin to have scholars, professors like Professor Duku here, who are scholars, but also indigenous health practitioners like Jamel and so forth, who are not dirty poor, who are serious scholars and researchers in their own right, very educated in that, and they're speaking the language and doing the work. It's part and parcel of the conversation. Tafadzwa, you're having a second bite, so please, can you make it snappy? Then we move on to Alois.
Thank you very much, Dr. Munya. There's my face burning in the Musina sun. It's a very interesting conversation. And I was also looking at the questions we have to be prepared to answer. Whilst we want this coexistence, I also see a Western control over issues of definition. How do you tell that? How do you qualify a traditional healer? Is it somebody with inherited knowledge or somebody with spiritual gift? And also, are we looking at a filtered recognition of saying what is medicine? Are we looking at something you ingest or something you rub on your body? Or we are going as far as medicine such as bring chicken eggs, a chicken cloth, break it in the middle of a crossroads, and whoever steps on it inherits your illness. And also, lastly, the issue of, with an example with religion, when a papa prays for somebody with HIV, for an example, and says, but do not stop taking your ARVs, which are Western, but they've practiced religion over that person and said, you are healed. Are we also looking at one who says, I'm a traditional healer, I can heal HIV, and then we've got Western control saying that person should not take ARVs because it will be against some kind of law? That is where I'm looking at now, and the questions that we might have to prepare to answer, and some issues that I know I'm not expecting answers now, but a challenge which might come when Western power starts controlling that coexistence as well. Thank you.
Thank you, Tafadzwa. I think we're all entering this conversation at different levels, which is welcome, and others have been at it for life. Others are only engaging it, and others are also engaging it with a very Western mindset of education and thinking, which then I think raises certain questions. But at the same time, Tafadzwa, I think there are still challenges to answer with the very education system that we are in, and which is not serving all. And it is also struggling. If we were listening to what Priscilla was saying with regards, to issues of forensic nursing, she's talked about a gap in people-centered healthcare. She's talked about a violation of the being or the inner person, and she talked about the need for cleansing, following certain things like sexual violence or gender-based violence and all that, and saying that the body is a crime scene. When you have been violated, how does the Western health system cleanse you, and so forth? But there are many things. It's not for me to answer. I will ask Tabitha and Sis Priscilla. Does anybody want to answer that before we come to you, Alois? Sis Priscilla, did you hear that those questions that were being raised by the speaker who spoke just now? So Tabi-san, would you like to take that? I don't see. Oh yes, Sis Banekas, you can also take that. Don't know what's
Thank
happening to
you,
Sis
thank you,
Priscilla here.
thank you, Doctor. I just thought let me try and assist. I think what is important, firstly, to understand is that all the issues we're raising come because systemically it's a system that wasn't designed with our worldviews in mind. And so, rightly said, we will have questions around, you know, liability, risk, and de-risking what we claim as a healing modality. And so it is precisely for that reason that platforms such as these ones are highly appreciated, because these are platforms that must enable out of us a mindset that says we are building our knowledge system first. So we are not engaging in the process to extract for other knowledge worldviews. We need to first understand the knowledge worldview that we are engaging. So in the Kamako framework, for instance, these checks and balances are there. You don't just wake up and become a healer. There is an extensive system that you have to engage before you even get to a point where we can say you actually are a healer. And unlike other knowledge systems, um, you can't spend a year, say, I went in, I trained, I'm done. For some, it's 5 years. In fact, minimally, it's around 5 years. For others, it's 10 to 20 years. So we need to engage. What are those things that make it longer? In some knowledge systems and in other knowledge systems, what makes it shorter? But I think in all of us doing that and engaging, in these questions, I think the gentleman who spoke then will feel affirmed, because even if they come, it's important that we build this for ourselves, because we are consuming it. We are in it. We want our people to be safe. We want to make sure that we deal with issues of HIV and AIDS. We must unpack these things for our worldview first. And having done that, then begin to say what parts of this are we able to commodify and market adequately so that we can replicate these skills. Well, some of them, you really can't learn them like you would in school. There are certain things that, even if you were taught to do these things, there are certain healing modalities that you can engage because they are bloodline related, and there are other reasons why you would never be able. So it's not everything that you can teach in a school setting or in an environment where you say you can train. Some of them, yes, you can. And of course, we can upskill for certain courses, things like counseling. And some of these things, we have them, we just have not codified them in a way that we understand. So we are always in a position where we have to codify for other people to consume our knowledge, but we don't codify for growing it for ourselves and our own consumption. And I think that's partly why in our communities, a lot of what we do doesn't get visible enough in terms of it being formalized. So I think to respond in a very simple way, that I appreciate personally the questions that were emanating, but those questions can only be addressed adequately when we are not piecemealing this thing, when we are looking at knowledge systems as a collective. And then we say, what do they look like in an economic sense? Because at the end of the day, somebody must produce that medicine, somebody must grow those plants, somebody must manufacture, process, others must think about, do we even use, how do we engage the medicines that they say are not working? And it's mostly because they are looking from a biomedical perspective, and we have a different science that we employ that has not been codified. So there's a lot of work, and there will certainly be a lot of questions that come out of that. And I think we should actually just be documenting all these questions. And I think this platform is one such platform that is beginning to do that. And it will help us when we all go now and support it Forte to bring these questions along. And I think as we move as a collective, because this has not happened, at least in the way I'm seeing it happening now. So we definitely are in the timing of it. And I think these are beautiful questions to be asking. But I think we should be mindful that some of what we think systemically the system will respond to are actually issues that should be coming from the family systems themselves. And so with a system of healing that in some areas relies on family systems, what do we do when the family systems are no longer conducive to support, for instance, young people who have to go through initiation? And so what does that look like for them? So there are responses to these questions. It's just that they have not been adequately researched, simply because the research itself is packaged in a manner that is not growing the knowledge system. It's got to feed into an economic model that must go and commercialize and give input into what is currently mainstream. And most of that doesn't speak to our worldview. Thank you.
Wow, thank you so much there, Sis Banekazi. You have said a lot, and in fact, as you speak, I'm busy identifying next speakers as we want to really have a series that will run throughout the year in 2026. So the next stop from here, colleagues, is the multidisciplinary IKS conference being hosted by Professor Duque and colleagues at the University of Fort Hare, where these conversations will need to continue. And beyond that, we should really be bracing ourselves for a series of activities in 2026 and towards some deliverable actions, things that will help, and for at least the generations that will stand on our shoulders, to start from somewhere and to start with, to continue with this journey of, needing to unlearn, relearn in order to learn. Over to you, Alois.
Okay, thank you so much. It's an interesting conversation. Maybe I have one or two things that I want to say, and some of the colleagues in here can take them to different offices and different forums for discussion going further. The first thing that I'm going to point out is the issue of acceptance of indigenous knowledge systems in our health system as an African continent. What's the first point? I think the first point is acceptance. And where does acceptance begins? It begins on self-consciousness and awareness as an African people. Because for us to decolonize our mind in terms of the health system, there must be self-consciousness and self-awareness to accept that there's a lot of African spirituality and a lot of issues surrounding our health systems as Africans. And if we get to acknowledge that, I think it's the first starting point for decoloniality. I think I've listened to a gentleman by the name of Joshua Maponga. I've listened to some of his sermons where he was talking about decolonization of the African mind, and he stated that self-consciousness and self-awareness is the most important thing. And as for our health system, I think it should be integrated into our health systems at an early age. The kids at school must learn about self-consciousness, self-awareness, decoloniality at an early age. Because as of now, to decolonize some of the minds, someone who is 50, 60, it might be a bit difficult to colonize that mind. But if we start at an early age, it will help in the future generation. Then secondly, in terms of indigenous knowledge system being integrated into our mainstream health, are our government ready to fund this discourse? That's the most important thing that we should ask in different forums and different offices as we engage different stakeholders. How are our governments ready to fund the integration of indigenous knowledge systems and the biomedical aspect into our mainstream health? Because on the 15% Abuja declaration, the allocation to health, to our health sector from our national budgets, out of that 15%, what percentage is being allocated to traditional or indigenous knowledge health? We need to know about that allocation. How much is being allocated to our national budget from that 15% that was declared on the Abuja declaration? From that 15% on its own, it was not enough. We were being sustained by US aid. Now that there are a lot of difficulties in funding and being sustainably standing alone as our health systems in Africa after the pulling away of US aid. How are we
Alois,
going to, yes?
I'm going to ask you not to give a lecture or get very long. I want us sharp pointed conversations, because if we get
Okay,
into lecture mode, then we got only 16 minutes left here. What are
okay,
your key points, so that
okay,
we either engage them
let,
or respond?
let me try to summarize them. My first point is about decoloniality through self-awareness and consciousness as an African people. Then the
No,
second
we
point,
heard you. We heard you. I'm not asking you to go over them. I'm just saying make a
okay,
subtotal of all that. Where are you going with all that? Make that one point.
okay, then the second point, the last point, is the readiness of our governments to fund the integration of traditional health and biomedical health. How are we ready as a African population to fund our own research, our own integration process? Thank you. I think these are my main 2 points into this discourse.
Thank you. Thank you so much, Alois, for that. And yeah, colleagues, Tabisa, I'd asked you to respond, if you may want, to some of the comments that were being made, or any other thoughts that are arising from your side as a result of listening to what is being said, or any afterthoughts based on your initial input. Over to you, Sister Tabisa.
Thank you, Professor Munya. I think what I'm taking from Professor Mpumlwana is the fact that we need to be intentional, and we also need to be very much aware before we even go outside in understanding what does it mean when we talk to indigenous medicine, and even our own processes, Fs, amagqirha, amathwasa, and all of those things. Because when we have a clear understanding of where we stand and what we stand for in our own processes and how they go about, it becomes quite easy to go and engage with government and people who write policies about us but not understanding us. Because when you're looking at policies, as she also have said, is that our systems do not talk to what we're talking about. Our systems do not talk to coexistence. And if then our systems, as much as the policy writers, which is we are very good in government in doing, if you want policy, you can fill a 5-bedroom house with all the policies that we're always writing as government. But when it comes to how do we implement, or even if those policies are implementable, that is a different conversation. And when we're talking about Africanism, you need then to understand what you are talking about in order for you to engage. And that when you are then challenged, you can answer to questions that are talking about you, not against you. And the question, for instance, that was raised around medical certificates and all of those things talks to that coexistence, talk to what we are all about, because our systems don't talk to one taking time ukuthi makahamba yothwasa. As much as ukutwasa is part of me being an African person, and if I go to my HR person and I say I want a 3 months leave, or I want a 6 months leave because in the Atwasa, I'm confronted with having to maybe resign and reapply into a job. Then you ask yourself what these policies then talk to, because then they don't talk to me being an African. They don't talk to me being holistically and being understood as a holistic African person who might want to go ayokutwasa. And what we have done in the Western Cape, as I was saying, as part of, we have a model that we are using, which is community orientated primary health care. And part of that, we're intentional in understanding that traditional healthcare practitioners must be part of that conversation. And we have to open the practices into the African culture. But also, I'm not going to lie here and say that it is an easy process. It's not an easy process, but at least we are starting that conversation and we are wanting to change towards that, and looking even in the question of, are our practices, are our clinics, hospitals allowing this practice? If then it's not allowed in our systems, then when we're talking about primary health care, community primary health care, that is then the extension of services where then we look at the facilities itself cannot offer this, but the extension of services can offer this. And how do we offer this and integrate it into the system? Those are the conversations that are there, but conversation have to happen with traditional health practitioners. I do not come from that space, and I cannot sit here and say I can talk for traditional healthcare practitioners. I understand some of the practices, but I'm not practicing or I'm not in the space. Then the conversation within government have to be a realistic conversation, and we have to be intentional, and we have to be real. We have to have conversations that are real, that we have not been doing it. The policies have been there, but we have failed in those policies. But where the relationship or the collaboration becomes and saying we are now willing to take the conversation and we open the conversation and the spaces as we are doing now, which is shaking the grounds as they stand. Because this conversation talks to the core of what I am part of. I'm not sure where this conversation is going to lead, because everything that I'm talking about, one can even say, I'm talking against the government that have employed me. But I'm also being very intentional in saying it is who I am. And if the government that employs me looks at me holistically, then I have to push to a position where I say, let's talk about me holistically. Thank you, Prof.
Thank you, Tabisa. Except that I'm not a prof, and yeah, Lolu Cindy. So I see you clapping a lot. I was going to put you on the spot and ask you to speak. And also, colleagues, just to let you know, Jamel is now in the room. We'll ask Jamel to speak. Just if you're fine with it, Jamel. He was facing a personal situation there that needed his full attention, and as a result, he couldn't be with us. We have had to proceed with the webinar, seeing this was our second time, and after rescheduling it, and we had the two sisters, Tabisa and Priscilla, driving and steering the conversations. Yeah, so over to you, Jamal.
Awesome.
Abraham will come to you.
Thank you so much, Dr. Munya, for that. And apologies, colleagues, for joining you guys lately. Just as Dr. Munya indicated now, I had a family situation. Regardless, mine was really to lay the foundation, but I also see that time is not going to allow me to get into my presentation now. So what I'm going to do instead is just quickly to respond to some of the questions. What I've heard, though, is that people were talking about the medical certificates and etc. What I'm going to say based on medical certification and incapacity leave, for instance, is really that the fact that I'm happy to state that our government departments, for instance, they are very forthcoming in terms of accepting certification that comes from traditional health practitioners, allowing their patients to take a leave. And that happens only now when we go through the entire incapacity leave process. Some of this happens for some patients. It's 30 days, a maximum of 30 days that you're able to offer such incapacity leave for, but and for some it's a maximum of 3 months. And we read that in with the section 51 of the Traditional Health Practitioners Act, which allows us transitional opportunity to still practice while allowing the act to get into full force. Now, that being said, we ask ourselves a lot of times, where are we at? And we know, for instance, we had the Witchcraft Suppression Act, we had the Traditional Health Practitioners Act number, I don't know which one that was, of 2003, but then we also have the Traditional Health Practitioners Act number 22 of 2007, and that is one that is currently active and enforced by virtue of a government proclamation. That being said, or with that act and us having some sort of a backbone for us to move at, we also started realizing that in 2015 they came with regulations, and us as traditional health practitioners, I noted Usis Tabisa mentioned that she's not a traditional health practitioner, she cannot speak for traditional health practitioners, fortunately, and as such I can respond on behalf of traditional health practitioners. So what I'm going to do very quickly is to just give a brief summary of what I wanted us to speak about, and that really thought of us looking
Jamal,
into
can I just interrupt you a little bit? I'm
Yes,
wanting to do this. Abraham Nguni has got a question, which I think you
Okay.
can then take with if anyone else might have a question. I was going to ask you to give us a very foundational basis and a summary of what you would have told us, because I'm seeing that a lot of us, although not all coming from the South African context, from some of the people who are on the call, we are joining this conversation at different levels, and others through the lens of the kind of education system that we have received and continue to see and perceive, and sometimes
Yes.
not quite get to understand the cracks and the difference of this particular system. If that will allow me, it may run a little bit, 5 minutes beyond, it's 15:30 if you do, but I think it will be worthwhile for those who might have the time and interest. So Abraham, may I ask you to make your question, then Jamel will come in giving us the summary and addressing your question at the same time. Over to you, Abraham.
Awesome. Thank you, Munya.
All good.
Thank you, colleagues. Good afternoon. Unfortunately, mine is not a question, but a submission that I would like to make.
Where are you coming from, Abraham? Just so that we know each other. Yes, your submission is welcome.
Okay.
But please don't make it long.
Okay. No, it's not going to be long. Abraham Nguni, the founder of Mobility Herbal Resources. We're dealing with the commercialization of traditional medicine from South Africa in Gauteng, in a small town called Vereeniging. My submission is based on the development and the research in traditional medicine. But first, I believe that we need to first define indigenous health systems, because where we find ourselves in the sector, we find ourselves confused in terms of how did we get these acts being enacted or being developed, whereas we have not clearly defined the traditional practitioners and the indigenous health systems for ourselves. In order for us to be able to then talk about integration and bring into and bridging the system between the Western and the indigenous health systems, we first need to know who we are, what we stand for. We cannot be talking about integrating something that we are not, in fact, that we are clueless about, that we are busy trying to find ways of developing, of ways of making it to be seen something as something that is going to be compatible in the new generation or the life that we live. In order for us to be able to do that, we first need to be able to define what is indigenous health systems in a broader spectrum, removing the Traditional Practitioners Act, removing all these policies that have been developed, but starting with who we are, what we stand for. I believe that is my submission. Thanks.
Thank you so much for that, Abraham. And I would really love to have your contact. And I think as we carry on with this series next year, we'd like to bring the likes of you and some professor from UFS who are doing research and pharmaceutical work around this. So Jamel, over to you. Please give us what you'd have given us. We build onto it. We will certainly need to have you, lead one of the webinars early next year, so that we all have a real foundational basis and have a couple of webinars as a series in order to develop something meaningful. Over to you, Jamel.
Thank you so much, Munya. Thank you so much, Gogo, obviously, for your beautiful reflection as well, especially coming from a healer like yourself. Thank you for representing the Traditional Healers Organization and all the other organizations that you are representing. So for me, I was really just wanting to look at the ontology, epistemology, axiology, and meta theory that brings us here, that I would have covered within my foundational presentation if I did. So for me, I really just wanted us to look that reality for us as traditional healers is relational, it's mutually layered, because we look at body, spirit, ancestors, and nature. And then we understand that in our space, knowledge is embodied and it's relational, it's validated through lived outcomes and ancestral witness. And for us, we move with Ubuntu, interdependence, reverence, reciprocity. The way when you go at Twasenyi and then you go and get initiated, somebody teaches you something that is replicable. It's you are able to do it again. So when you look at what the definition of science is, they constantly get back to it's something that you're able to do again. And the processes that we go through within our Ndumbas and within our spaces, it's something that is really replicable, if I can put it like that. So from there we moved, or I would have wanted us to move into what I've called earlier on the regulations, the 2015-2024 regulations, to quickly look at the progress and the pitfalls. And I don't have that much time, but I'm just going to mention that as traditional healers, we noted that these regulations do not speak to us and who we are as a person. And when I say person, I speak to us as a whole within this discipline of Kwelapha Kwesintu. And because they define categories, they also gave us minimum standards of education. But when you looked at those minimum standards of education that they're prescribing, you are unable to see how you're going to be able to articulate this into a qualification, whether that be now a qualification on the OQSFF or the occupational qualification sub-framework, or even the higher education qualification sub-framework. And what I also wanted to touch on was the 4 distinct categories that we have within traditional health practice that is currently legislated. But then we would also see that within these 4 legislated categories of traditional health practice, many of these overlap with recognized or registered professionals, like your psychologist linking with Abangoma when Izangoma is sitting in Dumbeni and telling a person about whatever they're experiencing, and immediately thereafter they are also providing some sort of therapy to the patient to understand what they're going through, linking them from where they've been to where they are at. And just simply when they give all these processes names, we start realizing now, or just to speak, also now has a name that doesn't sound like the name that happened in Dumbeni. So key observations that I want us to quickly look at is that overlap really does not mean redundancy, because it indicates complementary rather than competitive functions, because each profession really contributes to the continuum of care. And there's also what I call a regulatory inertia. That means the incomplete operationalization of the Traditional Health Practitioners Act that has constrained referral systems, private and public partnerships. For instance, it's very difficult for primary healthcare facilities to partner with local traditional health practitioners, because the National Health Act will tell them that for you to partner with another healthcare professional, they should be registered by some statutory organization. And our statutory organization, unfortunately, had not yet started the registration processes for traditional health practitioners. So when you look at that, you start realizing that traditional healers are currently living in a limbo, and they're still continuing to live at the margins of healthcare within South Africa. But over and above that, what we require is really design thinking, as I would have discussed in a little bit earlier, that really acknowledges epistemic diversity, including indigenous health knowledge systems and biomedicine as not parallel systems, but intersecting cosmologies. So what does the current landscape mean for health? It means that some are activating, and with this, I want to understand that some of my colleagues, including myself, are not in agreement with a particular lot of sections within Traditional Health Practitioners Act number 22 of 2007. But the reality is it is a national legislation with several of its sections already in force, as per proclamation number 29 of 2013, I think. 2014, because that provides, the proclamation really provides a legal skeleton, but what we realize is that there's still an institutional flesh that is missing. And so full inclusion for us really demands that we operationalize some of the dormant Traditional Health Practitioners Act sections, also operationalizing the resourcing and capacitation of the Traditional Health Practitioners Council, whether that one is still interim or whether it's now a final structure, I'm not so sure, but I saw that their letterhead changed from being an interim council to it being the referred to as Traditional Health Practitioners Council. So I think it's probably now permanent. And then integration should really not be systemic. It should be systemic and not symbolic, rather. And indigenous health just a reminder, it's not something that's alternative. It's not alternative medicine. It's really ancestral science. And as I often refer to it, before artificial intelligence came, we already had ancestral intelligence. So from this, I want us to take that through recognition, wants us to include policy, design, resource allocation, and research agendas. But above that, it also wants us to look at integration as a process of epistemic justice that ensures that every knowledge system sits at the same policy table, and that the future of public health lies in plural governance, shared responsibility, and mutual respect. So I tried to summarize everything that I was going to say. Also heard Munya saying that I should respond to Gogo Nobizita. Unfortunately, I didn't hear a question there. All that I can say is that I echo each and every sentiment that Gogo Nobizita has shared today. So I think for now, I'm just going to stop there in the interest of time as well. Thank you, Munya.
Thank you. Yes, Jamal was talking about a comment, I think, on what Abraham had said, but I don't know if that's the person you are referring to at the same time. But that is it, may. Colleagues, I think, thank you so much, Jamal, for giving us that. Of course, colleagues are not having the benefit of the slides that you were sharing. They began to share on Wednesday, but that is it, may. It is just to really keep us very glued and to really sit and think about a dedicated series on this very topic, in the coming year. For now, I think all roads must now be leading to East London, to the University of Fort Hare Multidisciplinary Eye Cares Conference from 1 to 3 December, for those of you who were able to align with those dates. Are there any final comments, colleagues? Professor Duku, yes, I did see that. I think I wrote to you in one of the emails with Jamal that let's see how we can collaborate and see what it could mean for the to plan right in alignment with each other. If you are going to be having webinars, how do they fit into your conference for next year and vice versa, or even co-hosting some of these? Since Baneka said, Prosa, what is it that we can do with all those, and Abraham, from where you are sitting and the work that you are doing, what is it that we can do? But most importantly, what short courses can we put together? It could be for indigenous practitioners. It could be even for those that may not really know. There will be one for, very sort of, what would I put it? For beginners, so to speak, even in terms of language and in terms of what is it that we could co-host and do together, and who among us may be the best to host some of these things that we may want to put together, be it a training and qualifications development framework, be it a short course, be it a certificate course, be it whatever. And it may be in very unconventional ways where things are done, be it at midnight, when when certain alignments in the stars and in the spiritual world are correct, to really do this thing in a very different way that is so different from how we've been framed and trained to understand education and science by this very system in which we went to school. How do we begin to divorce ourselves from that and work in a way that helps us to align and to help people to be able to understand? So we are all at different levels. Those who continue to see it as something they needed to defend because it is being demonized, because it is being called names, and those that are at a different level on the road. How do we share this and help each other to be able to understand the work that is before us? Colleagues, I don't know if there are any. Since Priscilla, I have not been seeing her. I'm not too sure whether she's still on the call or she dropped. I tried to reach through WhatsApp.
I quickly just wanted to come in. I see Gogon Lobista or Abram. Yes, you were speaking about the same person. Also just commented in the chat box. Abram said that I firmly believe that our approach and reason for seeking recognition as a sector was a premature move, as we haven't really had conversations as to what it is that we stand for, and hence we are running around the space as headless chickens. So I wanted to agree with Abram that yes, we are running around as headless chickens that doesn't really understand where we're coming from, where we're going. But I also want to say I don't think it was a delayed, or it was too premature. I rather think it was delayed, Because if we think about it, we start thinking that African traditional medicine existed way before Western medicine started existing. And today, before we start thinking about us getting some sort of a medication, be that now for high blood pressure or anything else that you can find in Dumbeni, the person with the first place that they think of is the clinic. And why are they thinking of the clinic as the first space where they can find healing? It's exactly because we haven't thought about the recognition for so long. We haven't thought about ourselves as more than just getting in Dumbeni and then you throw the bones down and you tell people what is happening, and forgetting that apart from us just connecting relationships and bringing everybody together, it's also about healthcare. Why do we have primary healthcare guidelines that are speaking of which pharmacological drugs to put together for certain illnesses and diseases, when we so many years later do not have equivalents of guidelines that put together ATM regimes that respond to diseases such as your cancer, that responds to diseases such as your HIV and AIDS. And a very brief example is the fact that, and there's no healer that is not going to agree with this because this is the truth. In our Ndumbas, we find people walking into our Ndumbas the very next day after they get out of a clinic where they've just had that they've been tested positive for HIV and AIDS, or HIV rather. And when they get into a Ndumba, they tell you, despite having pre and post counseling, they start telling you that I don't believe in the results that I got. I believe that someone bewitched me, that there's something spiritual that has to do with whatever I'm experiencing. And we need to then start re-educating the person as to how ATM and biomedical systems can start reworking. But the sole reason why the person is coming to us because they've been bewitched is how people has placed us to be as a people of healthcare. So now the only healing that we give is healing that has to do the removing of witchcraft and etc. So I really don't think that we are late in seeking recognition, but I do think ourselves as practitioners and as a body, we have not done a good job in documenting who we are so that people can understand us, that even the legislators then, when they are wanting to write policy about us, that they understand who we are. Even today, when we are saying we don't want regulations 2024, we are not sitting, we are sitting together as a whole, as a discipline and as a community of healers that has been called together, and we are saying, yes, we don't want this, and all the reasons that we're giving are all in alignment with one another. But we are also not sitting together to say, guys, the reason why we are not agreeing with this is that and that and that. A very mere example just with that again, Nobizita, and sorry if I'm going a bit long, Amunya, but I want to contextualize this as well. As a few days ago, or not a few days ago, a few months ago, I wrote to colleagues and I said, I have a small survey for you, and this was now a start of a pilot research program that I was developing, and I wanted to understand the competencies that we think we have as practitioners post Uktwasa and what we do in Dumbeni, because I know for one, what Nobisita does in Dumbeni is not what WLValo does in Dumbeni. And when I speak of WLValo, I speak of myself, but I also understand that I'm not going to say what I do as WLValo, because WLValo comes and he visits my body, interacts with my body, and immediately when he leaves behind a professional. Unfortunately, that professional happens to be me. So when someone decides, let me take you to court, they're not going to take WLValo to court, but they're going to take Jamie to court. Why? Because Jamie was the professional left in the care of the patient. Litosi came and gave Jamie insight, spiritual insight, which Jamie was supposed to to sift through as not only uDabula but also as a custodian of Dabula and the very different spiritual energies that move not only with Dabula but also with Jamio, because now Dabula could be coming from one side of the lineage and then Jamio could be moving with all these other people, and all of them somehow find a way for them to interlink and interconnect. And again, it speaks to all the Africans wherever they find themselves, in whatever space they find themselves, that their healing is not only the symptoms, it's about what you see, Maulahla Matambo. It's about what happens when you have that engagement into Minyaku. And it's really about us being too late for the recognition that my colleague is saying that we were too hasty seeking. In actuality of the fact, I will say that for us as Abela Pipendabuko, we should be saying, what are we doing? Who are we as Abangoma or as Amaklecha? Who is it that these different people are? Because already we know that everyone is not Iklecha. The same goes for Togoza. When we say Togoza, we already know. For an example, last year when they were giving fees and they said that traditional health practitioners will pay particular fees, there were some of my colleagues that said, well, some of us go through Ntwaso, and once you are done Twasing, you don't even practice. So who are these people? Then it simply means that we should come together and we should have a register of practicing and non-practicing practitioners. Because when I got in, shortly when I got in, I heard someone speaking about Gogo Maweni, and I also know of Gogo Maweni, I also know of Gogo's Kodini, and I also know of a lot of other Gogos that goes around by Gogo. And when you look into this Gogo-ship, it gets from someone that either claims to have gone through Ntwaso or someone that really went through Ntwaso, but what gets out of this or out of that is not something that we can relate to. And we already know that we have Umthetho Elishoba within our space as something that guides us as practitioners towards a common goal, towards a common discipline, towards a common ethic and a common professionalism. But we also know that while we have that, we are unable to control Gogo Mawini. We are unable to control Gogo's Koten. Whether now they are saying that they belong to the profession or not, but what we do know that when someone articulates that person, they articulate them to the traditional health practice profession of South Africa. For example, we cannot stop Zanzibar Scope when they are publishing fake Gobela, and all our Gobelas today, when you look at them, we think of them as fake teachers who look at or who does things such as those that we see on Zanzibar Scope. And again, all that I'm going to conclude with is that we are not late for seeking recognition, but we are late with seeking and finding ourselves within our own spaces and communities. We are late for allowing centers such as the Africa Center for Inclusive Health Management to look for or to create and curate and host us for spaces where we are going to discuss what Abela Pipendabuko should look like when they are in the mainstream environment fighting public health conditions such as COVID-19. The same COVID-19 where we saw Abela Pipendabuko playing a very front row or a frontline role at, while they are today still sitting backward. And these people today are sitting without any employment within the Directorate of Traditional Medicine. And this is the directorate that is governing traditional health practitioners. This directorate is also governed by a person that is foreign to traditional health practice. And I ask myself, Abela Pipendabuko, when you say that we are very early and we were chacharach in seeking recognition, sithini kahle kahle. Thokozani, thank you so much, Munya.
Right, that was yeah, it was a terrific speed there, Jamal. But I think that said and done, colleagues, we had to try and do justice to thanks to the glitches on Wednesday. What happened, but I think it's not going to stop what we are trying to achieve and to push here. Colleagues, I don't know if there are any comments, any final thoughts, but otherwise, I think from our side, we have already exceeded the time we promised to be together. But I'll repeat my call. Colleagues, if there are those of us who are waiting for what you are calling the formalization of some of these processes in this system, we are probably going to wait a long time. And maybe our children and children's children will do so. It is in the nature of power. Once people are on the other side, it becomes a system. And we are dealing with a system that may just as well not necessarily, codify some of these things. And how do we then push policy through practice and through building movements and having these conversations that will eventually get us where we need to? If we wait, we will be waiting for a long time. But that said, please, colleagues, do reach out. We would like to have a dedicated series next year. We'll have other webinars on other topics, but this particular one, we want it as a running series for some time, and then have very clear, specific deliverables that will be able to make a difference out there. And then how do we do it together? I believe there's so much work, more than the people that are available to do it. And there is a lot that we can do from our little corners and wherever we are. Thank you so much, colleagues. And then with that, see you next time. Please don't, stop getting in touch with us. Should you have any ideas, follow us on Facebook, follow us on LinkedIn. There are many connectors already among us. And then I think through those people, we should be able to put together a series of activities in 2026. Thank you, colleagues. All the best.
Thank you. Bye.
Bye.
Thank you. Bye.
Bye-bye, colleagues. Thank you.